Listen now to a talk I had with Dr. Chris Packard, professor at the Institute of Cardiovascular and Medical Sciences in Glasgow, Scotland. We cover lifetime clinical and economic benefits of statin-based LDL lowering in the 20-year follow-up of the West of Scotland coronary prevention study. Chris, welcome to ACCEL, and I think we're really interested in hearing your experience with the West of Scotland study and this 20-year follow-up.
Thank you very much. I should begin by saying a little bit about the study itself, how we conducted it, and then how we achieved the remarkable feat of getting the follow-up done. The West of Scotland study recruited from the population individuals with raised cholesterol, so the mean cholesterol is 190, which is high, and we recruited 6,595 men, and they were allocated evenly between pravastatin, 40 milligrams, and placebo. We treated them for 5 years and published the original results in 1995. We then knew at that point we wanted to follow them up long term because this was the first primary prevention trial with a statin, and we wanted to ensure that we were both not only efficacious but safe over the long term. So we reviewed the GP records and figured out how many went on a statin and how many didn't, and between the two groups, equal numbers of about 30% went on a statin after the trial finished. And then using our comprehensive population-based medical record system, which is electronic, we can fairly readily actually get the hospitalizations, the deaths, the cancer registry, and look at the long-term follow-up for the study. So that kind of paints a picture of how we got the data. The principal messages from the 20-year study are remarkably that if you treat somebody with an LDL-lowering drug, and we think that's the basis of what we did, there's a persistent benefit that goes over the whole period of virtually the rest of the individual's life. So that suggests that over the long 20-year follow-up, we saw a 21% reduction in coronary mortality, about a 13% reduction in total mortality. So there was a survival benefit, which was remarkable. So the individuals on the statin for a long period of time never ever caught up with the individuals on the placebo over the period. We have to remember that these individuals were 55 years old, relatively young when they started, but when we finished the 20-year follow-up, they were 75 years old. So we covered the period of premature cardiovascular mortality. We documented all hospitalizations, and we saw that there was a 27% reduction in the number of individuals who were going for revascularization. No difference in stroke at 20 years, but remarkably, hospitalization for heart failure was reduced 31% in the statin-treated group. When we looked at that further, we found that you got heart failure in two ways in our study. Either it was the first clinical manifestation, or it followed a first heart attack and a second heart attack. And it was those that followed precedent heart attacks that actually saw the benefit in the overall heart failure rate. We also calculated that the number of hospital days saved for an individual treated was about 2 over the 20 years. So it was cost effective. Given the cost of staying in a hospital for a coronary event is very expensive, that more than offset the cost of the drug itself. We found that the benefit was very focused on cardiovascular outcomes. Non-cardiovascular outcomes in terms of cancer and other cardiovascular diseases was absolutely equal in the two groups. The longer the follow-up went on, the more equal they became. So LDL lowering with pravastatin in this instance gave rise to no disadvantage that we could see in terms of non-cardiovascular events, but a clear, persistent, long-term benefit. So when we kind of think about these things, we say to ourselves, well, we've talked about long-term or lifetime risk, but really to evaluate a therapy, you want to talk about lifetime benefit. And that includes the first heart attack, the second heart attack, heart failure, and coronary death. And we can see the whole trajectory has been displaced towards benefit if you actually lower LDL for a prolonged period of time. That's important when we come on to consider newer results that have been promoted at this meeting in terms of ezetimibe, improve it, because we actually have to take, again, a long-term view of the benefit, not just a short-term view. So those are the main messages from our study.
So I've gotten used to the word landmark now. So what people are doing is taking a point in time after a study and then starting the observation period again. So I think we all were sort of driven by the West of Scotland study to understand that LDL lowering was important and it ought to be clearly a goal for treatment. So if I was to say, let's pretend there's a landmark, and you start at the end of the West of Scotland study and then look forward, asking how many of those patients stayed on a statin versus didn't, and whether that factor had a significant difference in outcome.
We were able to review the case records of these individuals 5 years after they stopped the trial itself, the formal trial. And we found that whether they were originally allocated to the pravastatin group or to the placebo group, at the end of the day, 30% in both of those groups were on a statin. 70% were not. And that persisted over a long period of time. So as far as we can tell, if you draw a landmark or a line in the sand, the line in the sand finishes at the end of the formal trial. After that, the treatments were the same. So any benefits that we see can be attributed almost entirely to the 5-year difference in their LDL levels, which was about 1 millimole.
Okay, so I think the message there is get people treated, encourage them to continue, but there's still a benefit even if they go through some period of treatment before they give up taking their medication. Another important question. We're really concerned about the diabetic signal nowadays. Did you have any data on incidence of diabetes in the population of the pravastatin patients?
Yes, we did. Interestingly, 2 things. Firstly, West of Scotland itself looked at incident diabetes, and we published, and it caused a bit of a controversy, that pravastatin reduced the incidence by a small amount of new diabetes in our population. But then we conducted a meta-analysis from our group that showed statin therapy in all the trials actually increased the risk of diabetes about 9%, new diabetes. We think it's driven in part by age, the age at which you start your statin. And if you start younger, it's likely you'll not have a diabetic impact. But if you start older, you might have. But the impact is very small compared to the benefits of LDL lowering with a statin. And therefore, although there's a small risk, there's a big benefit. And that's the trade-off there.
I think we now understand, I think from your meta-analysis and others, that even if there is a small increase in incidence of diabetes, the overall outcome, diabetes or no diabetes, is still better. So, a little extra blood sugar for a significant improvement in survival is probably worth the risk or worth the payment that you have to pay for the diabetes. A couple of other interesting questions here. There was always a question, even from your original study, of what I'll call pleomorphic effects of the statins. I think there was some signal in your data. There was something else besides LDL lowering. What's your thought about that?
We attempted to attribute the benefits in our study within trial to the achieved LDL levels. But to some extent that was stymied or hampered by the fact that almost everybody had the same LDL. They were all raised LDL levels, 190 going in. So it was very difficult to then look at the change in LDL and attribute a change in risk to a change in LDL. I think we are now pretty firmly convinced that it is the LDL that drives the phenomenon. This comes from a mixture of the genetic studies that have been done, looking at inborn mutations in PCSK9, LDL receptors, and now we know the cholesterol absorption protein. They all drive change in LDL and a subsequent change in cardiovascular risk. So although we have looked at anti-inflammatory effects and other pleiotropic effects of statins, the question is how much of that is driven by LDL itself, which we now know to be a very toxic molecule in terms of cardiovascular disease, and how much was driven by the drug. It's extraordinarily difficult to actually separate those things in any meaningful experiment. And over 20 years, lots of people have tried, and I think we're still where we started. So I think the default position is that it is the LDL reduction that matters, and that we can drive things down further and further, and we still see more benefit. And that's what came out of the Improve It trial. Down at 50 milligrams per deciliter compared to 70, you're seeing the benefit.
I always tell my colleagues there was these 2 people called Brown and Goldstein who won the Nobel Prize for identifying the toxicity of LDL, and that was a long time ago. And in spite of all the efforts at trying to find an alternative hypothesis, I think your data, the Improve It data that we heard, it's all supporting the LDL hypothesis. So I think we're getting comfortable with saying LDL should be down and we're going to improve long-term outcome. I think your data, 20-year outcome, is spectacular data to look at because it confirms what we've been working around all these years. So let me thank you for being at ACCEL. This is extremely valuable confirmatory data on some of the concepts we have right now. So thanks again.
Thank you very much.